Evening, everybody. You're most welcome to this evening's Let's Talk Equine webinar. This is, in fact, the last in the series for 2022. Your company is really appreciated, and we hope very much that you enjoy the next hour or so. This webinar is being recorded, and hopefully, fingers crossed, the technology works and we get to put it on YouTube and the www.teagasc.ie/Let's Talk Equine on the website in the next couple of days. As some of you might be aware, last month's webinar, we had a little bit of a technical glitch with the recording and it didn't convert. However, I can assure anybody who wishes to avail of that we are working to replace it, albeit that the interviews will be done without an audience. So we're hoping that we will be able to release that before Christmas even. So Francis and Shane and the Conleys are being very, very, very generous in giving their time to us again. But this evening we also welcome the interaction from you, our audience, and we welcome your questions to be submitted using the Q&A tab. So you can do that at any time throughout the evening. And this evening, I'm really delighted to be joined by Siobhan McAuliffe. Siobhan is a very busy person. It's an absolute pleasure to introduce you, Siobhan, so you can come and join me here. We're very lucky, I think, to have you with us here this evening. I really get the feeling that not only are you held in high esteem among your clients of your own practice, but also very much among the veterinary community itself. And I appreciate that you also are somebody who gives your advice to other vets in certain situations as well too, and are held in high regard in that manner. So thank you for giving your time and being with us here this evening.
Not at all, Wendy. Thank you for the lovely introduction. And I must say, I really like the photo that you put up of me. It's at least 15 years old. So thank you for that. Definitely made me feel good. So I guess I'll start sharing here. And
I suppose maybe before we get into that, Siobhan, just maybe to kind of reflect on the fact that we did have a conversation before we came to this evening. We talked, I suppose, a little bit around what was maybe of most practical relevance to serve our audience with this evening. And I suppose we did have the conversation that we had another webinar back in March this year with Jenny Henderson and Carmen Welch, and we did have quite a bit of discussion in that particular webinar around topics around neonatal healthcare as well. So, we're taking a slightly different avenue with the conversation this evening, but that's not to say that some aspects of what was discussed there would also, in your mind, be very relevant and very much of importance in relation to neonatal care as well. And I know you feel very strongly about, for example, colostral protection and so forth as well.
Yeah, because I originally gave Wendy a talk that I had, which was essentially all based around colostrum and essentially ensuring that you do have adequate IgG levels. So because that had been very adequately covered by Jenny and Carmel earlier in the year, we decided to take a slightly different slant on this, and that we're going to look at essentially early intervention and how to recognize when things are wrong. It's one thing dealing with essentially the healthy foal. It's another slightly different thing dealing with the sick foal. So most of tonight's talk is about recognizing that sick foal just that little bit earlier and knowing how to intervene and giving you an idea of what to expect from your vet when they do come to the farm, and also what you should have prepared to tell them and the questions that you would be expected to be asked and the information that's very important to actually tell your vet, which may lead them on a path to diagnosis before they even get to see your foal. Because I know anyway, for one, I love to have as much history as possible, and that you're already going through the list of differentials in your head before you even arrive at the farm. So you're actually better prepared to deal with the problem when it's there. And some people, even over the phone, you'd say to them, look, by the sound of what you're telling me, that foal needs to go to a hospital immediately. Don't even waste time getting someone out to the farm to look at it. And the big thing tonight is essentially minimizing your vet bills comes through early intervention. The quicker you get these things, the easier it is to treat them, the quicker the treatment will be, and therefore the less costly the treatment will be. That essentially they're all tied in together.
Yeah, and
okay, will we kick off, Wendy?
We will, absolutely. Thanks so much.
Okay, right, here we go, everyone. Stop me whenever you feel like it. So obviously topic of tonight's conversation is optimizing foal survival and reducing vet bills. So as we said, the big thing tonight is knowing how to evaluate these foals and then what early treatments are important. So the aims of any early intervention are 1, to stabilize the foal, 2, to assess the severity of the disease, and then number 3, decide, should this foal be referred to a hospital? Can it be treated on the farm? Do we need to do additional tests to find out what's wrong with it? And is it even worth continuing therapy or not? So how do we do that? There are essentially 2 main things. So the history is very, very important, and then the clinical exam. So the clinical exam consists of what I call the observational exam, which is there's an awful lot of information that we can glean just by looking at a foal, and then the hands-on examination. Now, obviously the observational exam can be done by an owner just as well as it can be done by a vet. And a lot of this really does come with experience and knowledge of foals, but a lot of tonight's talk is to kind of give you a guide as to what to look for. And then we have what we call the hands-on examination. Now, some of the hands-on examination would include things like taking the foal's temperature, checking their heart rate, looking at their mucous membranes. They're all things that can be done by an owner as well as by a vet. So with all of these together, we managed to decide what the requirements of the foal are. And essentially requirements of any foal can be summed up by 5 things. So ventilation, the foal needs to breathe. Without breathing, they're not going to survive. They need perfusion. So perfusion refers to blood being transported around the body. So the heart has to beat and the blood vessels have to work. Because again, if blood doesn't get round to the body, we're not delivering that oxygen to the organs. And without delivering oxygen to the organs are going to fail. Nutrition, they obviously need nutrition to survive. Passive immunity, that's what would have been covered earlier on in the year in terms of making sure that they've gotten sufficient immunoglobulins from the dam. And antimicrobial coverage if it's required. And then once we've decided what the requirements of the foal are, do they perhaps consist of some type of emergency procedure? And oftentimes it may be necessary to intervene quickly to deal with something that is an immediate problem or an immediate threat to that foal's life before we even continue with the rest of the exam. And usually emergency procedures revolve around ventilation and perfusion, because if they're not breathing and their heart isn't beating, they're definitely going to die. So history. There are 2 parts to the history. Number 1, was this foal normal at birth? Has it done everything a foal should have done from the moment it was born? So for example, this foal that has swelling on its ventral abdomen, was that there at birth? Was it there soon after birth? What sort of time frame are we looking at? So if you're calling your vet and saying, right, there's swelling on the belly, other important information is, okay, the foal is now 24 hours old. He had no swelling until 12 hours of age, and it is getting progressively bigger. Or it has appeared in the last 2 hours, or no, this swelling was there since he was born. Things that we would consider here would be things like scrotal hernias, which generally are present at birth or very soon afterwards. This is a 4-day-old foal that actually had a urine leak under the skin, and this only appeared at 3 days of age. So information like that, was the foal normal at birth? Oftentimes when we're thinking of things like that, we're also considering possible congenital abnormalities. So for example, the foal that was abnormal at birth, the foal that has been straining and colicky from within a few hours of birth. So as soon as this foal nursed, he was colicky. That would make us consider congenital abnormalities. So in the foal on the left, for example, this is an Atrasia coli where there's essentially a dead end to this intestine. So there's no way that this foal can pass feces, and these foals will get very colicky very quick. So very important information. So was it normal at birth? If it wasn't normal at birth, make sure you transmit that information to your vet.
And I suppose, Siobhan, sorry, Siobhan, just I suppose in you saying all of that, I suppose it's emphasizing the importance of breeders actually being present and you know, seeing what's happening from the time of birth and monitoring mares properly at that stage.
Yeah, and that's where things like actually foaling record charts come in very handy, because if you're actually forcing yourself to write it down, you're forcing yourself to take note of it and essentially memorize it. So, you know, things, for example, of how long it took the foal to stand up, how long it took the foal to nurse, did it pass meconium? Because, for example, with those Atrasia coli, they'll never pass meconium. And quite often when you're asking the question, it's, well, I'm not sure, maybe he did, maybe he didn't. Whereas if you have a foaling record chart and you actually force yourself to write it down, it makes you answer those questions in your head already, and you have things an awful lot clearer. Okay, so the observational assessment. So this, as we said, is, remember, the actual exam of the foal falls into two parts, the observational assessment and the clinical exam. So this is what I call the essential at the door assessment, particularly in terms of respiratory rate and pattern. We all know that if we walk into these foals, we startle them, particularly very young foals, and their respiratory rate in particular can go up. Now, in general, the pattern won't change. So pattern is the way they are breathing, and we'll look at a few videos related to that. But it's best to actually assess the respiratory rate from the door. Okay, so rate and pattern. Number one, is he actually breathing? So a respiratory rate of greater than 60 beats or breaths per minute is normal immediately after birth. And then it should fall to 20 to 40 breaths per minute within 1 to 2 hours of foaling. Any irregularity of pattern and a high or low respiratory rate is significant. Okay, so that's, if that's the only thing you take home tonight, it would be the most important thing, because what kills foals is respiratory failure and kidney failure. They're the two most common killers. And generally in foals, respiratory failure comes before cardiac failure. So usually their heart stops beating because they're not oxygenating well enough. So if you keep them breathing, you'll keep their heart going in the vast majority of cases. So for example, this foal is the first one we look at tonight. So if you look at him, you can see that he's essentially puffing out his cheeks and puffing out his guttural pouches, which is the space just behind his jaw at the top of his neck. So see, with puffing out his cheeks and puffing out his guttural pouches. This is an abnormal respiratory pattern that we see in foals that actually have central respiratory depression. So what we would call dummy foals, foals that have brain swelling, brain hemorrhages, they do this type of breathing. Now, prognosis with these in general isn't good. So if you notice your foal has this type of breathing, basically you're in big trouble, and there really isn't much point in calling your own vet other than to tell them you're actually already on the way to a hospital. Okay, so cardiopulmonary resuscitation. I know this was very well covered by Jenny and Carmel, but just to remind you of when it should be done. So if they're not breathing, they obviously need to be resuscitated, or if they're gasping, if they have absent or irregular heartbeats. Now, you really don't need to be a vet to assess this. The way to do it is you basically just put your hand on the left side of their chest, just behind the elbow, and you should be able to feel the heartbeat regularly. So what we say about irregular is if it speeds up and slows down, or if it stops for a couple of beats and then starts again. If your heart rate is less than 40 beats per minute, now that's immediately after birth, or if foals are non-responsive. And obviously foals delivered by C-section. Okay, so a couple more abnormal chest movements.
Sorry, Siobhan. Siobhan.
Yeah.
Can you hear me okay? Before you press on with
that,
I can. If you had a situation where, okay, the breeder is there, mare has foaled, the foal is not breathing as it should, but is not like it is in some of these videos or in the first video, but that it needs resuscitation. What can, it can often take a time for a vet to arrive in a yard. What can the breeder do themselves in that moment?
Yeah, there are essentially foal resuscitators. Now, the best thing to do is actually an endotracheal tube. So that's a tube that you pass into the trachea of the foal. You inflate a cuff on it, and we use what's called an ambu bag. You'd see them even in movies. The bag that the technician is essentially pressing in the back of the ambulance. Now, you're not going to do that at farm level, because believe me, getting these tubes into the trachea of a foal is actually quite technically difficult. But you can get foal resuscitators that actually fit directly over the nose of a foal, and you can use those. If that fails, you make sure the foal's mouth is closed, you close one nostril, and essentially you blow air into the other nostril. So you're essentially giving them mouth-to-mouth resuscitation. Just make sure that your own chest is filled fully before you blow into the nostril of the foal. A newborn foal's chest is about the same capacity as ours. But then meanwhile, you have someone else calling the vet. Or if you're close, throw them into the back of the car and get to a hospital as quick as you can. Like, one thing I never want to hear anyone saying is, oh, well, we're waiting for the horse box. You don't need the horse box. Put the foal in the back seat of the car, or the back seat, or the boot of the Jeep, or whatever, and get going as quick as you can. The longer you wait, you're decreasing your percentage of success with every minute you wait. Do not wait with these. Okay, I'm probably going to say that 300 times tonight.
Yeah, no, it needs to be said, though. It does need to be said.
Okay, so our abnormal chest or abdominal movement. So our foal down here on the left, you can not only see that he's making this great effort to breathe, and you can see he's using his abdomen to breathe in, but I'm not sure, can you see my cursor? Can you see my cursor on the screen?
Yes.
So you'll notice here that when he does breathe in, that he's got this space in his chest wall. Okay, so see right along here, if we follow the cursor. So what he has is, this foal has multiple rib fractures. So he's having difficulty breathing because his chest wall is no longer intact. So you can actually see one lovely fracture just sticking out here every time he breathes in. So that is obviously a very critical situation. Now, the first thing you always do, if you do notice that, if you can obviously notice rib fractures in a foal, so we see this foal as well, you can see that essentially this side, the lower end of his chest is collapsed. This is an older foal. You can also see the chest is collapsed. If you notice that, make sure that they're lying down on the side of the fractures. You never want the fractures up. Obviously, we did it in this case to take the video, but we did turn him over again straight away. And the idea of that is that the ground that they're lying against acts as a splint for their chest, because it's much harder for these guys to breathe if they're fractured side up. Now, you will get the odd foal that will have fractures on both sides of their chest, but the vast majority are just fractures on one side. So if you do notice chest fractures, make sure you turn the foal over and they're lying fracture side down. Okay. You can have obviously other types of thoracic trauma, diaphragmatic abnormalities. Now, generally, we don't see diaphragmatic tears unless they're associated with rib fractures. Now, they can occur, but you're talking a really, really tiny percentage that are just congenital tears. And even most of those don't even present until they're older. To have a neonatal foal that would present with a diaphragmatic tear without a rib fracture, I think I've only ever seen one in 25 years, so that they're quite rare. Now, severe respiratory disease will also give us abnormal chest movements. So we'll take a look at a few of those. Now, sorry, the start of this video is quite rough, but it does get better. Now, this is actually another rib fracture foal. So I wanted to take one standing up. Hang on, it does improve here now. So this guy, I'm not sure if you can notice it, but right here, he's got a couple of fractures. And you'll also notice with him that his respiratory rate is actually quite high. and his respiratory pattern is very shallow. So he's taking very quick, short breaths because it actually hurts him to breathe.
And Siobhan,
now this isn't
with those foals that are suffering like that, is it potentially harmful for them to be up and moving and, you know, on their feet?
No, not necessarily. That's really where assessment of the foal comes in. But in the vast majority of these, if they can get up and move around, the prognosis is actually much better. Now, if they're not inclined to get up themselves, I wouldn't necessarily be forcing them to, you know. And as I said, that's where getting your vet out, getting the level of fractures assessed, and trying to determine if there are other problems associated with those fractures is very helpful. So this is another guy. So you can obviously see that he's got an abnormality of his respiratory pattern. He's breathing very quick and very shallow again. And he also looks kind of essentially quite thrown down in himself. Now this foal, there was nothing wrong with his ribs and nothing wrong with his lungs. This foal actually had meningitis and he had a temperature of 107 at the time this video was taken. So fevers will actually elevate respiratory rate. I won't say they're quite like dogs, but when they get to the extreme end of fevers, they will actually start breathing quicker as a means of cooling themselves down. So yes, the vast majority of these will have a lung problem, but you will get the odd exception to the rule where there may be something else. Now this foal, this was the foal that kept on giving. This was a foal that was with me for about 3 weeks. We'd fix one problem and she'd decide she'd get another. So this foal actually has what we call a wave chest. So if you watch her breathe, her chest doesn't go in and out all in one. It almost seems to move like a wave. So she actually had very severe respiratory disease. This foal actually had influenza. This was during the 2019 outbreak, and she had very severe influenza. I hope you can all see that. She did make a full recovery. Now, this would be typical of a foal that has very severe lung disease. You can see the very marked abdominal effort that this foal is making to its breathing. And essentially what they're trying to do here is the lungs have lost their elasticity because they're full of cells and fluid. So this foal is using its abdomen to try to squeeze out any excess carbon dioxide that's in there. So this is a very severe pattern. If you see something like this, this foal is very sick and likely needs oxygen.
And what's the prognosis for a foal like that?
Without any other problems, generally quite good, about 85% recovery.
There's a couple of questions here just before you move on. Going back to the rib fractures, there's a few here just wondering what might cause a rib fracture, and a follow-through question to that: how is it possible to prevent it, and can you prevent?
Oh, yeah, yes, a lot of them you can. Now, obviously, the two big things are a big foal, or I guess the contrary to that is a mare with a very small pelvis. So maiden mares that may have previous fractures of their pelvis that essentially make the space narrow, or an extremely large foal. Most rib fractures occur, it's usually the foal's elbow actually pressing against the chest, just as the mare contracts. So that's why it's very important that when you are foaling, that there's one leg in front of the other, and that then extends that elbow out. And you're also pulling part of the chest forward. So you're bringing the chest out at a slight angle, and you're decreasing the risk of having those two elbows pressed against the chest wall. So foaling technique really is very important, that they are that way with one leg in front of the other, and basically try to minimize pulling. Where we will see this most commonly is farms that have a tendency to pull their foals. And I was actually only discussing this with another vet yesterday, that the best foaling man I ever dealt with. He used to always say, once you have the legs out and you have the nose, go away, make a cup of tea, go to the bathroom, and then come back. Because if you stand there looking at them, we have a tendency to get into a hurry to try to help them. And it's often we create the problems. Now, as I say, of course, you can get the big foal, you can get the narrow mare, but a lot of the fractures are actually almost human-made or man-made. Now, the worst of them usually happen in situations where there is some type of problem. You know, there's some type of dystocia, perhaps the mare is dying, the foal has been, you know, that there's been some manipulation of the foal involved, and we're all in a panic to get this foal out because we know we're pushing the time limit in terms of foal survival. And they're usually the worst ones. They're the foals that will come out with 8, 9, 10 ribs fractured or have fractures on both sides of the chest. But the 2, 3 fractures, which we'll commonly see, they're usually related with either bad pulling or big foals.
Mm-hmm. And there's another follow-through question to that again, which is, how would rib fractures then be treated or managed?
Yeah, the vast majority of them can be treated conservatively, which basically means box rest. Now, you are talking up to 3 weeks box rest with most of these foals. If you have less than 3 rib fractures, you would never consider surgery, because what happens in that case is the ribs that are either side, so we have three rib fractures here, and then the ribs that are either side, which are intact, they essentially act as splints, and your chest wall is going to remain sufficiently stable with only 3 fractures. So they usually don't need anything. Now, the exception to that would be if you have something over the heart that is severely displaced. So there's different degrees of displacement, which is defined by the number of millimeters between one fracture end and the other fracture end. So what we call mildly displaced is less than 1 millimeter, moderately is between 1 and 3, and severely is greater than 3. So obviously the severely, once they're greater displaced than 3 millimeters, they'll start tearing into intercostal muscle, they start tearing into diaphragm, potentially tearing into lung. But a lot really depends on the foal. Like, I've had foals who've actually bled, have torn their lungs so badly that they've bled into their chest, but the foal is up and nursing. And in those, I'm inclined to leave them well enough alone. A lot too will depend on the experience and the capability of the surgeon as well that you're dealing with. Repairing rib fractures is actually really, really difficult. It's a lot more, it's a lot trickier than a lot of people would think. So it's not something to be rushed into. So if you are suspicious that your foal has a rib fracture, first of all, it needs to be ultrasounded to determine how many fractures you have and how severely displaced they are. And then if there's involvement of any other organs, do you have laceration of the lungs? How close to the heart is it? Could you have any diaphragmatic problems? And basically decisions will be made based on that. But the majority of them are treated conservatively by box rest. Now, another thing on that is quite often we will see foals that are perhaps have rib fractures at birth that aren't detected, which can happen if they're only mildly displaced. And these may even be foals that have been palpated by your vet and deemed to be fine. The foal goes out, and 2 to 3 days later, you'll notice a small hematoma over the side of the chest wall. So they're rib fractures that, through the movement of the foal around the paddock, your rib fracture has gone from being a mildly displaced fracture to being a moderately displaced fracture, and is now causing some tearing of that intercostal muscle, which is what's giving you the hematoma. So if you see something that was normal at birth and now has a little bit of swelling over the side of its chest, keep that foal in until it can be looked at.
So again, emphasizing the importance of observation, regular and good observation.
Looking at them and noting that something is different from what it was before. Okay, so I'm sure you're all experts now on respiratory patterns. So we'll move on to hydration status. So a lot of this, again, can be assessed just by looking at the foal. So the indications of dehydration, obviously we all know about a sunken eye. A foal that looks really skinny or dry, their coat will appear dry. You can see this foal here on the right. that he appears skinny and that you see his bones clearer than what you normally would. That's because in foals, they don't have a lot of extra water. So they lose water out of the little bit of fat they have very quickly. So that then makes their bones that little bit more prominent. So if you notice anything like that, then we say you need to make more objective assessments of their hydration status. So that would include things like monitoring their heart rate, looking at their capillary refill time and mucous membranes, checking the pulse pressure and the skin tent. And again, all of these things can be done at home. So here's an example of a skin tent on the left, where you basically just pinch the skin on the neck. And if that skin basically stays in place, it should bounce back immediately because the skin is quite elastic. If it stays in place, you know your foal is dehydrated. And foals, again, you need to act very quickly. A foal is not like an adult horse where, oh, sure, look, we'll see how he goes. If your foal is dehydrated, call the vet immediately, because dehydrated foals go downhill very quick. And maybe a litre or two of fluid will fix him now, but in a few hours' time, his heart is already starting to fail, his pulse pressure has dropped, and what may have fixed him with a couple of litres of fluids now may actually require 2 or 3 days of hospitalization if you wait 4 or 5 hours. So their heart rate, as we've said already.
Sorry, Siobhan, before you move on into heart rate and that, what would be typical reasons that you could end up with these severely dehydrated foals?
Oh God, there's multiple reasons. So foals immediately after birth, any foal with any type of neurological abnormality. So, you know, your severe dummy or your mild dummy, a foal that's potentially born septicemic, any foal, even your rib fracture foals, your contracted tendon foals, any of these foals that basically don't get up and nurse normally and nurse a sufficient amount can get dehydrated very quickly. I've also seen, we'll say, contracted tendon foals where people think they're getting up and nursing, and they're getting up and they're nursing, but they're not nursing enough, because when they stand, they're so painful that they want to lie down again very quickly. So they'll nurse for 30 seconds or a minute, and they're definitely not nursing enough. Those foals can get dehydrated. Foals that have ruptured bladders, where essentially the urine within the bladder will pull any other fluid in the body into the abdomen, they'll get dehydrated. Any type of foal with a gastrointestinal problem will get dehydrated. So there's a multitude of reasons, and that again is why you would need to call your vet very quickly, because you need to find out exactly what is causing the dehydration in these foals. Now, the problem may be very obvious. Perhaps the foal has a raging diarrhea and you can figure out why he's getting dehydrated. But in other cases, it may not be so obvious. Perhaps there is pain associated with a rib fracture that hasn't been detected. Or I've even had a foal that actually had a fractured sternum. So different, there can be lots of different reasons, but essentially, if you notice dehydration, it needs to be investigated further. Okay. So
and I presume as well, also maybe to add to that, Siobhan, keeping a good eye on the mare's udder as well, and how well that's been.
Yeah, now that can be deceiving, because again, too, particularly in foals that are very young, or even in maiden mares, you know, there's a question then of how much milk they have. And quite often I'll hear people say, oh, no, well, you know, she looks nursed out. But perhaps the mare doesn't have very much milk in the first place. And mares, particularly mares very soon after foaling, they will start to dry up very quickly if the foal isn't nursing adequately. So if you have a foal that is painful in particular for some reason, and he's not nursing as much as he should, within 3 to 5 days, that mare could be completely dry. So you can actually deceive yourself into thinking that everything is normal by just looking at the mare's udder. Yeah. So if the foal looks dehydrated, has a skin tent, as we say, if the heart rate is abnormal, or we look at pulse pressure now, if there's any of those things, you need to investigate it a bit further. Okay. So as we said, the normal heart rate after delivery is anywhere from 40 to 80 beats per minute. Again, if it's below 40, you need to consider resuscitating that foal. So just because the heart is beating doesn't mean everything is okay. So if the heart rate is 40 and the foal is perhaps a little bit less responsive than it should be, than what you would consider normal, or if there's any type of abnormality to its respiratory rate or the respiratory pattern, that foal would need resuscitation, because its heart rate is 40 now, but in 5 minutes time, it'll be 20. And 5 minutes after that, it's possibly dead. So as I say, just don't wait on these. And again, it's very easy. You put your hand against the side of the foal's chest. What I would always say to younger vets is put your hand there. And basically, if you can feel a beat per second, everything's fine. If we're slower than that, we probably need to intervene. Okay. So the heart rate will rise to between 130 to 150 beats per minute within minutes of birth. And then it gradually falls back to about 60 to 80 beats per minute over the first week of life. Obviously, excitement and handling will cause elevations in heart rate. Right, capillary refill time in mucous membranes. Now, this is something that often isn't done by owners, but it's very, very easy to do. So basically look at their gums and see what color they are. So they should be a nice pale pink. So the foal on the bottom left is pretty much normal. So a kind of a salmony pink. The foal on the right, you can obviously see is redder. So that foal is either severely dehydrated or septic. So if you have mucous membranes that look like that, you definitely need to call your vet. The top left, that's a jaundiced foal. They're obviously very yellow in color. Anything like that, you would need to call your vet as well, because if you're not in trouble now, you will be in the next few hours. And the foal on the right was a foal that actually, this foal presented to me as a suspected dummy. The foal was actually seizuring on presentation. And what he actually had was he had a tear of an umbilical artery, and he was bleeding out into his bladder. So this foal actually had a PCV of 4 when he arrived in the hospital. So this foal, he didn't need anticonvulsants. What he needed was oxygen and blood. So if you look, again, just open their gums, take a quick look, it will give you a huge amount of information. Capillary refill time, that's when we press our thumb against the gums, generally just over where the teeth would be, and you count how many seconds it takes the color to return to normal. So it should return to normal within 2 seconds. If you get to 4 seconds or above, your foal is dehydrated, and you definitely need to call your vet.
And I'm presuming
pulse pressure.
Sorry, Siobhan, I'm presuming your advice would be in the scenarios whereby any type of irregular colouring to the mucous membranes that you're suggesting that people call their vet and get onto it.
Oh yes, of course. Any type of abnormal colour, call the vet. Now, as I say, it can be doing the capillary refill time literally takes between 2 and 4 seconds. So that can also be useful information for your vet. If you can say, look, I have done a capillary refill time, he's greater than 4 seconds. That lets me know that it's quite urgent and I need to get out there immediately, rather than if you tell me, well, you know, he's a little bit red, or, you know, it's slightly darker pink than normal, but his capillary refill time is 2 seconds. Okay, you know, I can maybe go look at the fellow who's not breathing next door first, you know. So again, it's just more information that, you know, that helps guide our thought process and helps prepare us for the possible differentials. And as I say, let's me mentally prepare on the road for what I'm going to do when I get there.
Mm-hmm.
Okay, so pulse pressure. This is something that's very easy to do and is quite often overlooked. So if you cannot feel your foal's pulse, he's either his heart is not working properly or he's severely dehydrated. So you can feel it in the facial artery, which is just under the jaw, where that picture is on the top left. The median artery, which is on the inside, the upper inside leg of the forearm. So you can see where the foal's nose is here in the picture. So here would be the elbow. So just here. So, and you should be able to feel that quite strong under your fingers. Always use your fingers. Don't use your thumb, because your own thumb has an artery in it. So you can mistake your pulse for the foal's pulse. And then on the hind leg, just below the hock, essentially where the bone meets the tendons. This is usually the easiest place to feel it. And if you cannot feel your foal's pulse, and if the distal limbs feel cold in the foal, that is quite urgent. In that case, then that means he's his blood pressure basically has dropped. So he no longer has a palpable pulse. And what happens in that case then is he himself is entering emergency mode, where he's shutting down the blood supply to the organs that he doesn't consider essential. And he's trying to keep the rest of his body going. But he can't do that for very long because he doesn't have the resources to do it. So those foals need emergency intervention very quickly. So this is just a graph of percentages of dehydrations and other signs you can see. Generally, dehydration less than 10% is really difficult to evaluate. You would want to be very experienced to do it. So if you're at 10 to 12%, your skin tent is going to last 5 seconds or more. Your mucous membranes will be dry. Your capillary refill time will often be greater than 4 seconds. Your heart rate will be greater than 100 beats per minute. Oops, we lost the end of that. And you'll have a reduced jugular fill and barely detectable peripheral pulses, okay? So your emergency intervention in this case is going to be fluids. And we may need to repeat that a number of times. So again, just to be prepared for that when your vet comes out. Usually on these foals, we'll try to measure their blood glucose before we give them any glucose. They either maybe have really low glucose or really high glucose. And then once we've given them, we give a shock dose of fluids, which for most foals is 1 litre. Then you reevaluate them, which means we feel their pulses again. We see if their limbs are starting to heat up, see if the foal is becoming any way more alert. Is the heart rate stabilizing? These are all things we evaluate. Okay, behavior of the foal. Is your foal acting normally? And again, a lot of these things we can detect from the stable door. So a normal foal, once you enter the stall, the foal should get up, go straight over to the mare and really should start nursing initially. It's that comfort nurse of, Mammy, who's this? Is this okay? Tell me I'm safe. And the only way they know they're safe is by latching onto the mare's tit. So if you have your foal on the left here who goes to Mammy, has a bit of a nurse and 2 seconds later decides, oh, I actually don't feel good enough to nurse anymore. That is a sick foal. So this is what we call milk face. So the mare has started to let down for the foal, but he stopped nursing. So he now has milk all over his face. That is a sick foal. If you notice your foal with milk face, you need to call your vet. So again, the foal should latch on and nurse normally. He should have a normal suck reflex. Does he see normally? So when he does get up, does he run into the wall rather than go to the mare? Does he recognize her and does he go to her, or does he just kind of stand up and stand there? If he doesn't recognize and have affinity for his mother, that's a very early sign of a dummy foal. So again, the foal that gets up and is perhaps a bit slow to go to Mammy, or the foal who doesn't get up when you get into the stall, they're all early signs of problems. And again, early intervention with those is usually better. Now, you may say to yourself, oh my God, I'm being a bit of a pain in the ass and I shouldn't call the vet, and oh, she's sick of hearing from me. But I would honestly rather get that call and be able to fix it now with perhaps a litre of fluids or some medication or checking its IgG, rather than having a foal that's recumbent and seizuring tomorrow morning.
Prognosis is better the earlier you can.
Oh, the prognosis is way better the earlier the intervention. Now, onto that, recognizing seizures. This is frequently an area that kind of that goes wrong. So we see our guy up here on the right who, he seems to be licking his tongue a bit and kind of chewing and not doing that much. And then we have the guy on the left here now, who we all recognize as a seizure. He's throwing his head back, he's paddling, he's quite violent. That's an easily recognizable seizure. The guy on the right, however, this is also a seizure. This is what we call a chewing seizure. And any type of seizure is critical, because with every seizure, they are actually causing further damage to their brain. And if seizures go untreated, they basically get worse and worse. And then they get to the point where they can't be treated.
What are typical reasons for these, Siobhan? What would be at the,
again, most of these Yeah, a lot of these would be what would fall under the, you know, the very broad term of dummy syndrome, or neonatal maladjustment, whatever, or hypoxia, whatever you want to call it. So, and again, there are numerous reasons for that. So any type of birth asphyxia, so a hard pull, some of these may even be premature, the septicemic foals. The guy on the left here, he actually had tetanus, and these are literally tetanic seizures in this foal. So there are numerous different causes. So again, if you notice any type of seizure or any type of behavior essentially that isn't quite normal, make sure it's investigated further. Perhaps this foal is septicemic and you haven't realized it yet and he needs antibiotics. So the foal on the bottom right here, he used to demonstrate his seizures. He would put his head down between his legs, looked like he was just going to have a sniff of his bed, and he would basically put his head in so far that he would actually fall over. And then he would get up and do the same thing all over again. So he wasn't having that violent seizure. And, you know, oftentimes people will see these foals and go, oh God, isn't that funny? Isn't that a cool little trick you can do?
Isn't that cute?
So that's not a trick.
Yeah.
Yeah, isn't that cute? But he's actually having a type of seizure. And we all know that, you know, the foals can kind of get this chewing, kind of submissive response. But if they do that without having reason to be submissive, that can be a form of a seizure. So if you're standing at the door, looking over the door, the foal hasn't actually noticed that you're there, and he's doing this repetitively without actually being in a fearful situation, that is also potentially a seizure. And that would probably be the most common one that's missed.
There was actually a question earlier on, and maybe it's appropriate to ask it now when you mentioned the other foal here with tetanus. One of the earlier foals that you suggested had influenza. Were the mares vaccinated in these cases?
No, is the short answer to both of those. Now, the mare with the influenza foal, she was possibly vaccinated. That 2019 outbreak, that was a new strain of influenza. Now, I'm suspicious that she wasn't vaccinated, or if she was vaccinated, she wasn't vaccinated appropriately, because the mare herself also got sick. Obviously not as severely as the foal, but she was also sick. I was told she was vaccinated, but I was a little bit suspicious that perhaps not adequately. And the tetanus in this case, this was actually an extremely valuable foal. This was a show jumping foal. This was an embryo transfer foal, where they actually hadn't thought to vaccinate the recipient mare. So the foal hadn't received any tetanus antibodies in the colostrum, and hadn't received an anti-tet, because a lot of foals won't get a tetanus antitoxin if the mare has been vaccinated, which really is the ideal thing to do, to have the mare vaccinated within a month of foaling, ideally within 2 weeks, and then she will provide sufficient levels to the foal, and it will actually last longer than giving them an antitoxin. But that hadn't happened in this case. Okay. So obviously, if you notice any type of seizure or any way suspicious, your foal will need some type of anticonvulsant so that it doesn't injure itself, injure anyone else, or do more damage to itself. Size and maturity. Sorry, I'll just take a sip of water here.
You're okay. You're working very hard for us here, Siobhan.
Now, this is very important because a lot of these foals in general have a poorer prognosis. So it's important to notice if you know, particularly if there's any issues in particular about their maturity. So if they look like they're a small size for their breed or their gestational age, so the foal is at term, but it looks a lot smaller than what it should be, that can be a sign of what's called intrauterine growth retardation, where basically they haven't grown normally inside, because what we say, they've been living in a hostile environment. So either the mare could possibly have had some type of placentitis, they may have been exposed to some type of infection in the uterus, and quite often these If the foal comes out, you notice it's very small, take a very good look at the placenta. Now, I know that again was also covered by Jenny and Carmel in the spring, but it's very important to not only look at the placenta, but also measure it. And if your placenta was excessively heavy and you have a small foal, you possibly have an intrauterine growth retardation. If the foal appears very weak, so they have trouble getting up, or they're very slow to get up. If they have a fine, silky hair coat, so you see particularly the foal on the left, a really, really short, fine, soft hair coat. And quite often these will have soft, floppy ears and lips. Now, there's a very distinct difference between the floppy ears on the left and the floppy ears on the right. We'll quite often see floppy ears like the guy on the right in some of our dummies or some of our foals that are actually, they're born to term, but they're what we call a bit dismature. So they're a little bit slow about things, but they will generally do well. The foal on the left, you're really going to be pushed to try to save him. Your likelihood of saving him is extremely low, and he's going to cost you an absolute fortune in the process, okay? A very domed forehead is also a sign of immaturity. So you'll see this guy on the left as well, also has quite a lot of doming here to his forehead. And then incomplete ossification of the tarsal and carpal bones. Now that can really only be definitively diagnosed with X-ray. But if you have foals whose knees and hocks look particularly weak, so the foal that goes very, very back at his knees when he stands up, or the foal who appears to have really curvy hocks when he stands, they may have incomplete ossification. So if you notice that in your foals, you should definitely get those joints x-rayed. The foal may be okay, he may be able to stand, move around, he's nursing fine. But if he has incomplete ossification, and if you turn that foal out, you are in danger of crushing bones that are actually immature and essentially giving him a lifelong problem. You may create a lameness that's there for life, or you may end up with a foal that has a curvy hock for life. So the synechium, the synechium is this soft rubbery stuff that's at the end of the hoof. That should fall off within 12 to 24 hours in most foals. If that stays in place for longer than 24 hours, that's a sign of immaturity. These foals will have increased susceptibility to cold. So they're the foal that gets really cold and is very cold to touch, without it perhaps necessarily being that cold outside. And perhaps he has nursed, he's had his colostrum, he really shouldn't have a reason to be cold. But as I say, if you actually touch him, he's really cold. Reduced tolerance to oral feeding. So these are the foals that they're small, they're weak looking, and as soon as they're fed, they start to colic, because basically their gut is also immature. Abnormal respiratory patterns, as we've seen already, and a lot of these foals will have an abnormally red or orange tongue. Okay, another thing to always look for, the last thing essentially to look for, we've assessed whether they're breathing properly, we've assessed their hydration status, we've looked at whether their behavior is normal. Another thing to look at is there any obvious abnormality that we can see? So is there milk flowing down the nose, for example, soon after they've nursed, which may be an indication of a cleft palate? Or is there any obvious limb abnormality? Do we have contracted tendons? Do we have severe limb deviations? So basically, it's not just, oh yeah, he's out, he's grand, away we go. Make sure that the foal is up, and always assess the foal. I like to always take them out of the box, because obviously, they're probably going to be knee deep in straw. And it actually can be very difficult to assess whether they've got any type of flexor laxity or contractural deformity within a bed of straw. So take them out, stand them on the hard surface, all is good with the limbs, back into the stall, because I've seen it happen all too often where a foal gets up, he nurses, but perhaps he has a contracture, and he may nurse or appear to nurse okay initially, but then as the night goes on, he's getting more and more painful and is less inclined to nurse because of that contracture. So our hands-on clinical exam, we'll just take a quick look at things that can be done. So as we've mentioned, taking their temperature, very easily done. Get yourself one of the more expensive thermometers, the ones that will take them in in a matter of seconds. They're definitely worth their weight in gold and the few extra euros they cost. Hypothermia obviously can be associated with severe disease, an extremely cold environment, or a very poor technique in taking the rectal temperature. So when you are taking the temperature, make sure you've got the tip of the thermometer against the wall of the rectum, that you haven't stuck it directly into some meconium. An elevated rectal temperature is significant and is an indication of infection or toxemia. But remember that severe pain, such as you can see with limb or rib fractures, or even severe contractural abnormalities, can also result in elevated rectal temperatures. So if they are hypothermic, it's very important to warm them up, but do that slowly with blankets, heating pads, so you can put hot water bottles. But a mistake that I always see, even in hospitals, is people putting hot water bottles on their chest. Don't do that. Put them around the sides, but don't put them on top of the chest, because you're obviously making that work of breathing that much more difficult. And lamps, heating lamps are always very useful, but obviously be very careful that they're not too close to the foal. And this was when I worked in the Middle East, that I wanted to plug in the lamp, and obviously the plug wasn't quite the right, wasn't the right plug for the socket that was there. So the fella just stood on the plug, broke it, pulled out the wires and stuck them straight into the socket, which I didn't perhaps think was the safest thing in the world. And it's always very important to check the glucose levels of hypothermic foals. So if you have a foal that is extremely cold, and if its rectal temperature is very low, you definitely need to intervene, put blankets on the foals, put a heating pad on it, and make sure then and call your vet. And don't feed them. Don't try to bottle feed a foal that is very hypothermic. So if you have a foal that has a rectal temperature of less than 35 centigrade, do not feed it.
What would be the outcome of that if you did, or what could be?
Well, basically their gut will have stopped working, and they may end up essentially refluxing that milk back up into their lungs and essentially drowning themselves. So the way to deal with those is essentially get them heated up first. And once we get their temperature back up to about 36.5, then we can feed them. But they're not going to, they're not going to die for the want of waiting half an hour or 40 minutes to get their temperature back up, but they're definitely going to die if they drown in their own reflux. And a lot of people can just get into a panic about, oh, he needs a bottle, he needs a bottle, he needs a bottle. No, he needs his temperature up first. And if he hasn't nursed at all yet, then we'd be looking at tubing him very small amounts rather than getting into a rush of feeding him with a bottle. Okay. So hyperthermia, we generally consider treating a fever once they're over 38.6 centigrade. How we'll decide to treat it is usually dependent on what's actually going on with the foal. I like to avoid non-steroidals at all costs. So I hate Banamine, or Flunix, as we would call it here, or Bute is a definite no-no for any type of neonatal foal, particularly if they're dehydrated. I would say, if in doubt and you happen to have this medication in your cabinet, which you absolutely should not have, don't give it. I would rather cool them down with ice baths and alcohol until I know what's going on. I've seen far too many foals die of renal failure because they actually received Flunix while they were dehydrated. And those foals are very difficult to treat and very expensive to treat. So again, for the sake of waiting until the foal has perhaps even had a litre of cold fluids to cool him down, and also replace whatever dehydration he has, I would always wait on the Flunix. Shall I go on, or are we? How are we, Wendy?
We're good for a couple of minutes, Siobhan. There's no harm to cover these, I think. Yeah. If you're able to, is your voice okay?
It'd be grand for another while. The boys would be delighted that I won't be able to shout at them to get to bed when I get home. So I just wanted to cover a few of the more common things here. Now we've moved away from, the absolute severe things that need immediate intervention and perhaps hospitalization, but these are very, very common problems that I think everybody sees on a very regular basis. So just a couple of points on them. So flexor laxity. So this is what we see here. So basically the flexor tendons at the back of the leg are essentially looser and more lax than what they should be. So this results in the toe pointing upwards. The hoof isn't kept flat on the ground. The toe points upwards. The foals may walk on the bulb of their heels, or in very severe cases, actually walk on their fetlocks. It can be associated with prematurity, dysmaturity, or it can happen in some foals. Foals can have contracture of the forelimbs and laxity of the hind limbs, so that's not necessarily unusual. So the treatment depends on the severity of the condition, but many improve spontaneously with controlled exercise. And what we mean by controlled exercise is generally keeping them in. So if your hoof fetlock angle is less than 45 degrees, the foal will benefit from the placement of heel extensions. So that would mean that our hoof is here and our fetlock is here. So if it's less than 45 degrees, so if we're down here, for example, then heel extensions would definitely help that foal. However, we need to wait 2 to 3 days to put them on. So you need to wait until your synechium has fallen off and the foal or the hoof wall has dried out enough so that the extension will actually stay on. Okay, so here is an example. So you can see obviously this foal on the left, his toe is well up in the air. He's walking on his heel bulbs. So we put a heel extension on him. Now the heel extension should always extend back to the level of the back of the leg or a little bit further. Now, if they go a bit further, they can be hard to keep on, but you can see how much this foal has improved by putting these on. So his toe is now touching the floor and his fetlocks and his heel bulbs are off the floor. And these foals will actually get better an awful lot quicker if you can get heel extensions on them. So here's another more severe case. So again, you can see he's almost down on his fetlocks. Now these are commercially available heel extensions. These are called Dalerics. I don't like them in that generally they're not long enough, in my opinion, because by the time you have a foal that actually needs them, they usually need considerable more length than is what is available in the Dalerics. But if there's nothing else available, you can see they still help. They've still definitely improved this foal. He's now no longer walking on the back of his heels, but they're not going to improve him as much as if he had a full heel extension.
With a foal such as that, how long are they likely to need those extensions for, Siobhan?
Well, they usually only need them for a week, max. So a lot of people will wait and they'll say, oh, sure, we'll see if he improves and we'll see if he improves and we'll see if he improves. Whereas if you went ahead and got the heel extensions on him, he'd be improved before you know it. You know, now a lot of them will do fine with just box rest. And as I say, if he's greater than 45 degrees, box rest is all you need. Or box rest combined with very limited turnout. So we may say turn him out for an hour or turn him out for 20 minutes or 40 minutes or whatever, depending on how bad the laxity is. But there's an awful lot of these, particularly, as I say, the severe ones that are down walking on their heel bulbs that really would benefit from heel extensions. And it's something that I actually don't see done that much here. It's not something that people are very used to using, but it definitely does help them. The big thing with these is absolutely do not bandage them, because people look at them and they think, oh, well, he's going to damage himself by walking on his heels, we'll put a bandage on him. That actually makes them worse. If he looks bad enough that you're worried about him doing damage to himself, then you need to try to get some type of heel extension on him, okay? If there is a current contraction of the forelimb, don't minister tetracycline if the angle of contraction is less than 45 degrees, okay? Because they're actually the opposite. So this foal who has a slight contraction here of his front leg and perhaps has laxity of the hind legs, we don't want to make the hind legs worse by giving him the Oxytet, but if we can bandage the leg that's contracted, but you don't bandage the leg that has the laxity, okay? Are you with me?
Yeah.
Now this, I always like to put this picture in because this is completely different. This was actually a complete rupture of the suspensory apparatus of this foal, which is extremely rare. But how you note the difference is this foal has his fetlock on the ground, but his toe is also on the ground. So if you see this, your foal does not have flexor laxity. He has a much more serious problem. So a flexor laxity will always have the toe off the ground first. Okay. So tendon contracture, these have very many causes. It's genetic, dietary, intrauterine space restriction, hormonal. Treatment, again, treatment depends on the severity of the contraction, the number of the limbs that are affected, if you have laxity of the other limbs, and you also then need to consider other problems. So you can see this guy, he has contraction of one front leg, but he also has a bit of laxity to these hind legs. Now he's severe enough that he's going to need Oxytet for this front leg, and his back legs aren't that bad. You can see he's just barely got the tip of his toe off the ground here. So the severity of the condition, mild. If we have a normal hoof ground contact or only a very slight raised heel, then controlled exercise and physiotherapy may be enough. Okay, so the foal that just appears to be a little bit upright, but he is actually touching the ground. You can see this guy perhaps has a little bit of his heel off the ground. But again, turn him out, bring him back in, turn him out again for an hour, bring him back in for 3 or 4 hours. A lot of these will do fine with controlled exercise. Moderate, if the foal walks on the toe, but can bear weight and walk. These foals, these require bandaging, oxytetracycline, and controlled exercise, and they may need some physiotherapy, okay? If they're severe, now to be honest, this guy here, I would consider this leg as moderate and this as a little bit more severe. You can see he's almost ballerina, tippy-toeing on this one. So I would probably give him the benefit of a doubt with bandages and Oxytet for the first day, but he would want to be considerably improved by day 2 for me not to cast him. Severe, if the foal bears weight on the dorsal aspect of the hoof wall and cannot stand or walk without assistance. So these foals require splinting or casting in addition to other treatments. Now, what will frequently happen is you'll have one leg will be normal and one leg will be severely affected. So these foals can hop around and they can nurse, and then people don't necessarily see the urgency about treating these foals. But if they cannot bear weight and walk normally on both legs, the leg that is affected will need pretty radical treatment. So this guy, so this will be typical of those. So he has one leg, he can hop around fine, but obviously he's tipping over onto the dorsal hoof wall of this leg. So this leg needs a cast or a splint. Preferably, I prefer casting.
If somebody ignored that and left it, you know, and left it go on a couple of weeks, I mean, how much are you changing the potential outcome, positive outcome in that scenario?
Radically. Yeah, radically. If these are left longer than 10 days, you are going to end up with a foal that's shootable. Because what happens is that tendon then actually contracts fixed in that position. You come back to that. And unfortunately, I've seen it where you get the call that the foal is a week old and he's been like this since birth. And now you cannot get that limb back into a normal position. And as I say, it was something that would have been treated about a week ago is now resulting in you killing this foal.
Yeah.
You know? Yeah. So as I say, I like casting. If it's just one limb that's affected, you make the cast on the normal limb, you cut it off, and you put it on to the abnormal leg. Okay, hang on now. So we see our foal here on the right. So this was him, and this is him after 3 days of casts. Okay. So again, this is a foal with just a severe contraction of one leg. So you bandage the normal leg because you can get that leg into as much extension as possible. You make a cast on the normal leg, you cut it off, and then you reapply it to the abnormal leg. Okay.
How long would they
Oxytet.
wear those casts?
Yeah, anywhere from 3 days to a week. Now, it's very important that the casts are placed properly. So absolutely never attempt that yourself. a big risk is actually cast sores. So it's very important that they're bandaged appropriately under the cast. And then it can be very painful for these foals, particularly if they're very severely contracted, that you forcing that limb into a normal position can be really, really painful for them. So some of these foals may need painkillers as well. They may need assistance to stand because they can actually find it hard to stand with the cast on. They may need you to help them kind of get into position for nursing, particularly if they have casts on 2 legs. It can be very difficult for them to move around. And as I say, it can be very painful. On some of these foals, we'll only be able to put the casts on for 4 hours, maybe have to take them off, give them a break because they're just in so much pain, and put them back on again, and do that over a period of days. Most foals now, I would say, I get away with putting the cast on fully for a day. Then I'd usually be able to cut it, split it, and make it into a splint then that can stay in position for about 3 or 4 days. But obviously being very careful again that they're being watched and monitored. So the foal who's managing fine with the cast and is getting up and nursing, and then he's suddenly not getting up so well with the cast, that may be an indication that you've got some type of cast rub or sore under it that's going on. Okay. The oxytet, I just wanted to mention, you always want to use the minimum dose possible. It is severely nephrotoxic. This will absolutely blow the kidneys out of your foal. So you really want to make sure that your foal is definitely nursing adequately if he's on oxytetracycline. If he's on it for more than 2 days, his kidney enzymes should be checked. So don't complain about the cost of running the blood. We're just trying to make sure that your foal is not going to die of kidney failure in a week's time. And as I say, it's a drug that's extremely useful, but definitely does have side effects that we need to be very, very careful about. As we said, the placement of these can result in extreme pain, and this can be marked by either hyperventilation, fevers, or a decrease in nursing. So you can require analgesics in some of these, anti-ulcer medication, because this is obviously extremely stressful for the foals. And as I say, splints, initially they may have to be on a 2 to 4 hour on-off rotation if the foals are in severe pain. One little final thing here, or one close to final thing here, this foal looks like he's got contracted tendons. So you can see he's falling over onto the dorsal hoof wall, but he actually doesn't have contracted tendons. If you look at the image on the left, he's got a slight bulging on the lateral aspect of his knee. So that will be right here in this photo. So this foal actually has a rupture of a tendon. This is a rupture right here. So he can't stand. So this is not contracted tendons. He doesn't have a problem with the tendons at the back of his leg. He has ruptured a tendon on the front of his leg. So just watch out for that. This will actually quite frequently happen with foals that do have a moderate tendon contracture, and they seem to be doing okay, and then suddenly they appear worse. And this can quite often happen after maybe they've had a couple of days of oxytet. It's nothing to do with the oxytet, but you think the foal is getting better, and then suddenly he looks worse, and people will say, oh, well, you know, I think he needs another shot of oxytet, or he was fine there for a couple of days, but he's bad again, so maybe he needs more oxytet. Be very careful that you actually look at their knees, and if you see this bulging, and this will actually be quite soft and jelly-like to touch, then he perhaps has a tendon rupture. Now, these can do very well, but they do require casting, and they actually require casting to above the knees. So these can be quite difficult to manage at home. Joint contracture, just a final thing here. So this is less common than tendon contracture, but it's a relatively common cause of dystocia. So we'll often pull these foals out, and when you get them out, you can't get their leg into a straight position. This results from fibrosis of the joint capsule, but the causes of this actual fibrosis are thought to be quite similar to the causes of joint contracture. So genetic factors, dietary factors, uterine space restriction, perhaps some hormonal factors. But the big difference with this is that your prognosis isn't nearly as good as it is with tendon contractures. So if we think in this foal, his leg in a normal position should be down here, right? So this means that his angle of contracture of this is actually, he's actually moved more than 45 degrees away from what would have been his normal angle. If that is the case, the prognosis for this foal is likely to be extremely poor. And the way I always essentially work these foals is if you sedate the foal and you cannot, absolutely cannot manipulate this to a degree that brings me back closer, not necessarily fully there, but closer to a normal angle, I will not be able to fix this foal. Okay, and essentially what I've done, this, as I said, this is the scenario that we all hate. So this was the terminal C-section where we deliver the foal. It's not breathing, its heart's not beating, we resuscitate it. We get the catheter in, we get its bloods going, we get its tube in, we're all delighted with ourselves, patting each other on the back. We've all done a fantastic job. And then we finally look at its legs and realize that he's at a 90-degree angle and we have to put him down. So these can be very, very heartbreaking cases. So if the limb can be manipulated into a normal position, you can treat them with, there's all types of bandages, tube splinting, oxytetracycline, physiotherapy. This is a rather gruesome image, but this was the foal that we saw earlier. This is to show you that this is actually, it's a fibrosis of the joint and not tendons. So what I've done on a number of occasions with students is I will go and I'll serially cut the tendons. So there's 2 tendons here. We'll cut the superficial, we'll cut the deep, we cut the flexor tendons above the knee. And then I actually go as far as cutting all the muscles, stripping the skin back, and you can see that this joint is at the exact same angle. So no matter what you do to this foal, you're never going to be able to fix him. And then just the last little thing is watch out for other congenital deformities. So things like atrasia anis. So make sure you also have a look under their tail. Make sure you look at them from above, that you don't have any type of spinal deformities. And if you see milk at their nose, as we saw earlier, take a look in their mouth for any type of cleft palate. Any other questions?
I mean, Siobhan, I think we could all listen to you all evening and continue to learn from your vast experience. It's very interesting to listen to you. Maybe if you just stop your screen share there for a moment. One last question that I did get in here from a viewer. What causes the contracted tendons in the foals?
Yeah, as we've said, there's multiple causes. Genetics are definitely a huge part of it. When I worked in the Middle East, we had one stallion in particular that every single foal of his had contracted tendons. So that's a huge part of it. Diet, overfeeding pregnant mares will definitely do it. There's a very definite link in cows to high protein levels during pregnancy causing contracture. That hasn't been necessarily proven in horses, but is suspected. And then, as we say, those massive big foals in small mares where they just don't have enough space, they're much more likely as well to have contractures. So you can have one or all causes in any given foal.
The clock has really and truly beaten us. As I say, we probably have the amounts of 2 presentations in one there. It was so nice to have you on and so interesting to listen to you, and it's very clear that your depth of knowledge and experience with these neonates is massive, and I can see very clearly why you are somebody that others go to when they have problems. There's a number of people saying, you know, reflecting what I'm saying myself, fantastic presentation, thanks, etc. They're coming in there. So look, before we say a final good night to everybody, maybe if I could just ask you, you know, what would you like people most of all to take home from tonight's presentation? What would be your parting advice to anybody?
Oh, I think always just like, don't wait with foals. If you're any way concerned, pick up the phone and at least talk to your vet. And they will know just by what you're telling them if this is something that needs to be seen, or as I say, if this is something where they're going to tell you, right, throw it in the back of the car and get to the hospital as quick as you can. Don't be afraid. Don't think, oh, I won't bother them, I won't disturb them, oh, it's too late, or sure, it's probably nothing, or he'll be fine in a couple of hours. Learn what's normal, learn how to recognize your healthy foals, and then just pay attention, and you will notice anything that's abnormal, and anything that's abnormal, act on it quicker, particularly in foals less than 10 days of age. Do not wait.
And I suppose perhaps maybe the other side of the equation is that sometimes the prognosis is just not going to be good, and maybe, you know, there are scenarios where one has to listen to a different type of advice as well.
Yeah, they're not all fixable, unfortunately.
So look at massive thanks from me to you. Definitely, like so many comments coming in here across the Q&A. Really appreciative of the information this evening. All I can do at this stage is say a huge thank you and a happy Christmas to you and your family, and a happy Christmas to our viewers tonight as well. And until the next time in 2023, it's coming fast. Good night to our viewers. Good night to you, Siobhan, and thanks so much. When I press the lovely red
Thanks
button,
for asking me.
you're most welcome. It was a delight to have you, and I hope at some time in the future that we can get you back, maybe on a different topic again. So good night for now.
Okay.
Thank you very much.